So I would like to introduce Dr. Criado, one of our moderator and friend. And you will speak on...
They can read it on the screen. It's right there. It's okay, Jack. We need to get going.
Diverticulum Kommerelli.
Thank you. So this is a little bit of a different topic. Kommerelli was a German radiologist that described this very clearly, including that original diagram that you see in front of you in 1936. However, there were other findings much earlier than that, all the way up to 1735, as you can see, and 1761, when someone, Bayford, described the extrinsic compression of the esophagus. The term dysphagia lusoria, which is an interesting term still being used today in the 21st century, comes from the early 1800s. And then, as coming from that, the designation of arteria lusoria was put in front of us in 1926. It was Kommerelli who made the first clinical diagnosis of esophageal compression by a posterior coursing lusorian artery with a diverticulum. And you can see there in this case, much more recent than all of those references, why a large diverticulum can really compress the esophagus and cause swallowing difficulties. Lusoria, because they noted that although there were swallowing difficulties, there was no intrinsic esophageal lesion. So they called it lusoria, which means essentially unreal. But it is very real for these patients when this happens. There you have that case. The aberrant subclavian artery, the so-called arteria lusoria, courses behind the esophagus in 80% of the cases, or it can go between the trachea and the esophagus in 15%. Rarely, only 15% of the times, it courses in front of the trachea. Kommerelli's diverticulum is a remnant of the dorsal aorta in the embryo, and it is always associated, again, always associated with an aberrant subclavian artery. Good to know. The reported prevalence of this particular configuration is 0.7 to 2%, and that's what is now being called Kommerelli type 1. This is the classification proposed by Salomonowitz in a paper, and it is the most reasonable way to classify these lesions. So K type 1 is associated with a so-called normal anatomy of the aortic arch, and it is, of course, associated with an aberrant right subclavian artery. And there you have another image of how one might treat it today with an endograft in the aorta and closing off the aberrant right subclavian artery beyond the aneurysm with plugs or perhaps large coils. Also, one might be able to preserve the continuity of the vessel by using a parallel graft periscope type technique that would actually be quite useful in that particular setting. Kommerelli type 2, on the other hand, much even more rare than type 1, is associated with an abnormal or anomalous right-sided arch, as you can see there. There are actually 4 different types of right-sided aortic arches, but I'm not going to bother you with all of that. It is, however, important to remember the most common type, which is type 2, a right-sided arch with an aberrant left subclavian artery. Left subclavian artery is the aberrant lusorian vessel. It accounts for 40% of all right-sided arches cases. It is associated with a Kommerelli's and a right-sided descending thoracic aorta as well. The descending thoracic aorta courses in the right side of the chest, not the left. It rarely produces symptoms and is usually incidental, although, as a finding, it can infrequently cause esophageal or even tracheal compression. Rarely, it is associated with other cardiovascular abnormalities or anomalies. Somehow this doesn't work. To advance the slide. It is remarkable that these cases, no, go back. It is remarkable that these cases of right-sided aortic arch, they all look almost exactly the same. These are 3 different patients. And as you can see, the anatomy is remarkably similar, always in that sequence. The first vessel going from the heart up is a left common carotid, the next is a right, the next is the right subclavian, and the left is the anomalous left subclavian artery with a Kommerelli's. This patient, the one from the left there, is a 58, or was then a 58 a few years ago, year-old man who was referred to us with a large Kommerelli's diverticulum associated with an aberrant left subclavian artery and a right-sided arch. He had had a recent right posterolateral thoracotomy in the aborted attempt by a thoracic surgeon to surgically expose the lesion and remove it, but he realized soon enough, unfortunately after having opened up the chest, that this was too much to deal with, and he decided to bail out and close him up. He tolerated that okay, and then he came to us for management. There you have appropriately labeled all of the various vessels on this patient, again with a type 2 Kommerelli and a right-sided aortic arch. He was treated in our department with a staged approach that involved first a median sternotomy with an extra-anatomic bypass from the proximal most ascending aorta to the right and left common carotid arteries. And the second stage involved a right carotid to axillary bypass, as well as endograft placement in the arch and the thoracic aorta, as you can see on the right side of that slide. In an important publication 12 years ago, almost 12 years ago, from the Cleveland Clinic in 2014, they summarized their experience with these pathologies, and they illustrated and described some possible approaches, surgical and hybrid approaches, including this one, which is endograft treatment for the distal arch and the descending, combined with an open aortotomy for antegrade introduction of the stent graft. Perhaps more usefully, if this hybrid approach with a kind of bypass that we did on our patient via a median sternotomy followed by the endograft implantation and closure of the aberrant left subclavian artery, as you can see there. No matter what we do, it is important to close off that subclavian artery beyond the aneurysm in order to avoid backflow pressurization of the lesion. It is also important that we place whatever device we place there in somewhere that is well away from the midline, because that can cause problems with the esophagus, especially in this configuration of the Kommerelli type 1. How do you measure a Kommerelli, or any saccular aneurysm for that matter? Well, I'm not going to give you a full discussion on that, but it is a matter of good consensus among experts today around the world that the best measurement is the so-called transaortic technique that you see there on that red dotted line that goes from the apex of the aneurysm or diverticulum to the normal opposite side wall of the aorta. In addition to measuring the opening at the base of the Kommerelli's diverticular. When that measurement, the transaortic measurement, exceeds 5 centimeters, that's when we should consider elective repair, or when the other measurement exceeds 3 centimeters. But the more important one is a transaortic measurement beyond 5 centimeters, as I just said. And there you have, again, a patient presented with a mediastinal compression symptoms of esophageal compression. Finally, there is a type 3, so-called type 3 Kommerelli, which is really what I like to call it in a publication that we did some 11 years ago, non-Kommerelli, because it's actually not a diverticulum, but it's sort of an incipient diverticulum, as you can see on that case, illustrated on that slide. So that's it, folks. Thank you.
Thank you very much, Frank. I have a compliment for you because it's a very didactic and very well presented.
The pictures are pretty, anyway.
And you are good. My question in the Cleveland, when they opened the aorta, were they on pump or no? Were they on pump, circulation extracorporeal?
Absolutely, yeah, yes, you have to do under cardiopulmonary bypass.
Did you do that yourself? Some type of...
What we did was the bypass. When you do the bypass, you do a side clamping of the ascending aorta. But if you do an open aortotomy, then you have to go on bypass, yeah. That's why the side clamping and extra anatomic bypass is a better way to go, it seems to me.
And the one with the thoracotomy, they found the lesion and they go away.
Well, they just realized that it was going to be incredibly difficult and dangerous to approach it from the right or the left, and they realized that they were wrong and they better close him up before it was too late. They did make the right decision, a little late, but they made the right decision.
And then they send it to you.
Yeah, and the patient recovered from that thoracotomy just fine, fortunately, yeah.
Dr. Donald, do you have a question or a comment?
Really, not a question, but an observation that in embryology, there is the rotation of the gut as the gut forms and the colon comes round. And it looks to me, as I was watching your images, that it's slightly similar, that the aortic arch hasn't properly rotated because you can see the abnormal presentation of the left carotid artery coming off early, almost like an abnormal rotation. That's right. The second thing I'd say is, it must be exceptionally rare. I have never seen a case of this. And presumably, it's in the population, but doesn't cause symptoms. And then of those very rare occasions where it exists, very rarely there's a compression problem, or perhaps nowadays, CT scans are done so often that it's detected as an incidental finding.
Yeah, they are quite rare. We've had the opportunity to treat a good number of them, like 5 or 6 of them, but I saw many, many more because as you and I were talking about yesterday, I believe at one point, for many years, I was kind of one of the main global readers on CT for Medtronic from around the world. And so we get images from all over the place, the US included. And in that activity, I came across a good number of these right-sided arches and related things like that. Yes.
By the way, who in the audience have seen such a case? Don't go too fast. You.
They do exist, right?
Only one person from Romania.
I haven't seen such case, but as I have started to operate many years ago, a lot of kids, I discover all these double arch syndrome vascular rings. So I strongly believe that if you scan all these kids when at birth, and I think all kids should have a proper cardiac echo, and when they get a little bit older, if there is a doubt, to get a CT scan. And then you have all these vascular rings that will transform in something like this if you don't correct.
It's part of the same spectrum.
Exactly, yes. Which are easy to correct. You go like for coarctation, you do a left thoracotomy, you don't have to go on pump. and you correct it, and then you will never get that in the
Yeah, the
in
right-sided
adult
arch essentially is a partial form of the vascular ring.
Exactly. Exactly. So that's very important. Scan everyone early, and you will never see this in the adult population.
So the next patient, no, the next speaker, the patient are in the hospital.
Hopefully it won't be a patient.
So who's next? Bryce Renwick. Where is he?
Good morning. Can you hear me?
Oh yeah, where are you from?
Good. Well, nice to see you, and it's a privilege to address the conference. I'm in Aberdeen, in Scotland, in the UK.
Oh, how is the weather over there?
Listen, we don't have a lot of time for the weather, but maybe later. Good to see you. Go ahead and make your presentation, please.
Absolutely fine. Good. Can you see my slides? Okay.
Not yet.
We can see you, but no slides.
You look good.
Thank you. Can you see my crossbow now?
No slides yet.
Ah. How's that now?
Now we got it. Yes.
Very good. Okay, great. Well, it's a privilege to be invited to speak, and I'd like to share with the audience a case that we had recently up in Aberdeen. I'm part of the North of Scotland Trauma Service. We cover the entire North of Scotland for major trauma, and I'm very privileged to be part of the team up here. I'd like to share with you a case of a young man with a troubled past who came to see us with a crossbow quarrel in his chest. This was a Wednesday morning. We'd got a full angio suite prepared because we'd had to cancel an endovascular aneurysm that morning because the patient wasn't well. And this man walked as stable as you like into the resus department. He'd had an incident with a crossbow. This man had a troubled past, I think it's fair to say, and had a crossbow bolt to his chest a few hours ago at the time of presentation. He'd been absolutely stable, no sign of hemodynamic or respiratory compromise, despite a significant injury to the chest. He was so stable that it gave us a little bit of a puzzle to fix because a very, very complicated injury. So I'd like the audience just to think about how they would manage such a patient if they came into their department. Obviously, we're all working different hospitals with different specialties and subspecialties available. And I think we would all manage this patient according to ATLS principles, but also according to what facilities we have in our hospital. When I teach the registrars on this case, I think it's very, very important to have in the back of your mind the indications for resuscitative thoracotomy. This patient was obviously very stable, walking, talking, and breathing room air with no compromise. But my real concern during this case was that this crossbow quarrel tip could become dislodged, or the entire quarrel could become dislodged with rapid decompensation. So I think it's worth having a think about the indications for resuscitative thoracotomy. They're up on the screen just now if anyone needs a refresher. So this patient was managed according to TLS principles. We have seen a few impaling injuries over the year, and sometimes positioning the patient for cross-sectional imaging can be very difficult. Positioning them in the scanner can be very difficult. And especially if there's significant protrusion from the upper chest, sometimes it's difficult to achieve proper airway control. But thankfully, this patient was extremely stable and allowed for good cross-sectional imaging and a mini multidisciplinary team discussion. Here is his CT scan. This is a sports crossbow, and the carbon on the shaft of a sports crossbow bolt does not show up in CT scan. So you can see there's a X-ray void through the whole mediastinum. That's not empty space. That's definitely a crossbow quarrel. Excuse me, I'm going to cough. Excuse me. but you can see clearly the flow void from the crossbow and also a steel tip in the paraspinal tissues. What we're looking at here is a through and through injury of the entire superior mediastinum, just skirting to the side of the sternum. But this bolt goes entirely through the pulmonary artery on the patient's left and through the descending aorta. It's also going through both lobes of lung and into the paraspinal tissues. I should say that there was no neurology in this patient, so there was no suspicion of spinal injury. So there is the definite injuries that we've seen, both lobes of lung through and through, a kebab injury to the pulmonary artery and a kebab injury to the aorta, and no spinal cord injury, as I've said. There's a patient's plain film showing no pneumothorax. So, you know, we discussed a pull and press, or probably more appropriately, a pull and pray strategy, obviously contraindicated in this case. But the key question for me looking at this patient was how stable is the quarrel. It's obviously not come out on his transfer to hospital, but my concern was when we opened the chest, would the quarrel become dislodged before we had opportunity to get proximal control of the aorta or the pulmonary artery. So the key question for me was how stable is the quarrel. So running through the ATLS algorithm, we're going to manage this airway until definitive repair, but there's not an active airway issue. In terms of breathing, we know we're going to have to open that chest, but his right side of chest is absolutely fine. So we planned for a dual lumen tube, which is unusual in trauma, but very possible in a cardiothoracic theatre. And then we need to have a strategy that can both temporize and then definitively treat the mediastinal and major vessel injury. And at the time of CT scanning, he's definitely got 4 holes and 2 major vessels, plus any other small vessels that the bolt has gone through. And this patient was still very, very stable. And at this point, he had asked us to phone his work and tell him he needed a day off, which gave us a little bit of light relief at the start of a very serious case. So we took this man for a general anesthetic and a dual lumen tube, and we did this in a cardiac theatre in case we ran into serious trouble and needed to go on bypass, which is a very nice option to have. And we did discuss doing this all by open surgical repair, but the downsides of that are until you have the aorta made clampable with a significant foreign body in the way, this becomes a slightly difficult set of proximal control to achieve. And there's potentially 4 or more major bleeding points in this case. So after a bit of discussion about this case, we all agreed surgical strategy and timing. I advised in conjunction with our cardiac surgeons that we put a percutaneously placed thoracic aortic stent graft up the descending thoracic aorta and leave it undeployed. And then it means that if we run into trouble or the quarrel becomes dislodged, we have the option to deploy the stent very quickly. But the provisional plan was to leave the stent undeployed, perform a thoracoscopy to evaluate the injury, and then open the chest from the left and proceed. So this is in a cardiac theatre, so I don't have good angio pictures, unfortunately, but these are all fluoro pictures from a C-arm. So you can clearly see on the left of the screen, you can clearly see the crossbow bolt, double curve Lunderquist up to the aortic valve. And on the right, this is a 45 degrees lateral projection. You can see the stent grafts then placed. If you squint your eyes, you can just about see the quarrel, although as I've said, the carbon doesn't show up particularly well on an X-ray, but you can just about see the tip of the quarrel. So that's the thoracic endograft across the aortic entry and exit points. I'm sure the audience are very familiar with thoracic aortic stent grafts. We used a Gore C-tag. You can leave these for quite a while undeployed, and then they deploy in 2 stages, which is worth knowing about if you're having to deploy them in a hurry. And this was all done percutaneously, which is our standard practice, ultrasound-guided puncture and 2 pro glides, or pro styles as they're now called. This is all percutaneous from the right groin. And then the findings that once the stent was in place but not deployed, opened the chest, and as expected from the CT, found through and through injuries to both lobes of the left lung. So the ends of these were stapled off, which was pretty straightforward. Descending thoracic aorta dissected and made clampable. At this point, it became clear that the quarrel was pretty well anchored into the paraspinal tissues and was really not for moving, which made things harder and easier in various ways. Also opened the mediastinum, controlled the main trunk of the pulmonary artery, and it's the branch with the quarrel through it was skeletonized and controlled. This was the most difficult part of the procedure because, as you know, it's a very friable artery, and any traction in the artery did give rise to significant oozing with the quarrel in situ. But throughout all of this, the crossbow bolt was remarkably stable because of anchorage in paraspinal tissue. And then we clamped the pulmonary artery. This man was on single lung ventilation to the right by this time. Had a quick check of the stent position with my C-arm, and then we, with great difficulty, removed the quarrel. And this involved a significant force having to be applied to the chest. So my worry about the quarrel being unstable was probably unfounded, but I didn't know that when we planned this case. Then chest packed, and then packed the chest, and then in short order deployed the thoracic stent, which I would say worked extremely satisfactorily. There was very minor ooze from the aortic holes, and but that settled very nicely, and then surgically repaired the left pulmonary artery with standard technique, but a little bit of 6-O-proline, and that was absolutely fine. And because of all this, the patient was remarkably, and I'm very grateful to say, very stable throughout. And this is his post-op CT scan. This is still in intensive care the next morning. We've kept him asleep just because of the magnitude of injury. You can see the surgically repaired pulmonary artery there, very slight stenosis where the bolt's been removed, but good flow down the PA, and a very nicely positioned thoracic aortic stent graft in the proximal descending. This patient, I'm happy to say, did not require a blood transfusion and made a very straightforward recovery and discharge. What I've learned from this case is that teamwork between the trauma anesthetic team, cardiac surgeons, and the vascular team has to be fantastic. And we concentrated very clearly on clear communication in what was quite an emotional situation in terms of quite a dramatic injury. Be careful with projectile weapons, obviously. And when I was planning and looking at this case, I remembered the traumatology teaching from Dr. Mattox's book, which says, when you're looking at a difficult trauma situation, think about how well does your solution fail and what position will you and your patient be in, which is why I thought the thoracic stent was a good idea. Thank you for your attention. I've got another presentation after this, I think, but I'll happily take some discussion now.
Frank?
Well, thank you very much. This is a remarkable case.
You are the most experienced of us. What is your real appreciation of this case between you and me?
I think it's a remarkable case, and it was handled just superbly. You know, I am really surprised that things went so well, but obviously it was a combination of luck and also how well they planned for it, and how they sequenced the various steps. Does anybody have any further? Yeah, Donald?
Hi, Bryce. Really, really well done. It has come across beautifully here. My observation is you did incredibly well not to remove the crossbow from his chest, and indeed the individual himself didn't, with his friends, try and do this. That would have been surely certain death. Did you think about putting a proximal balloon up to have ready in case of hemorrhage? if you had thought of that, you could have used a retrograde carotid approach for a big balloon. And I just wondered if you had any thoughts of that at the time.
I did think of that, and obviously there's many ways of playing this, and there'll be hospitals without facility for cardiac bypass and hospitals without facility for thoracic stenting. So yes, I think everyone in the audience would do this differently depending on what facilities they have available in their hospital. But yes, absolutely, balloon occlusion very well described for horrible trauma situations. Absolutely.
Bryce, thank you very much. It was a superb case that we never seen. Maybe the military doctor on the field, sometimes they can have something like that, but not in civilian practice. So do you have something to say to end with your presentation?
I do know a number of military doctors actually, and in field hospitals they certainly don't have the opportunity to put in anything like a thoracic stent graft. So I think the military solution to this would just be good old-fashioned surgery, and I think if that was what was performed in this kind of case, I think that would also be very appropriate.
I have a last question, very short. How many doctors have been working on this case?
This case was very well publicized in the hospital because it's such a dramatic injury. So there was a very, very large team of doctors, nurses, radiographers.
How many doctors?
I mean, including intensive care, 20, 30, like there's a very large number of staff.
30 is a good number. Thank you very much.
Thank you. What's next? Is it live?
Bryce, you go on. Are you
That's
ready?
Great. I'm absolutely ready. As long as you're not bored of my voice, I'll happily keep going.
Yeah, keep going.
Very good. So to continue with the thoracic theme, I've also got several trauma cases involving thoracic endografting for blunt thoracic aortic injury, which is a big part of our practice. So I live and work up in Aberdeen in the north of Scotland, which is a very nice place to live and work. And we're also very close to the north of Scotland, and some of the audience might be familiar with the North Coast 500. So this is a 500-mile drive around some extremely beautiful and scenic roads around the north of Scotland. All the roads are extremely picturesque, a very beautiful part of the world, but these are all very narrow roads as well. And because of the popularity of this route, it's very well publicized in the motoring press, and some people have got a tendency to drive around it a bit too fast, despite the roads being very narrow and not really set up for high-speed vehicles. You'll see loads of sights on your way around the North Coast 500. But unfortunately, a number of these tourists will come off their motorbikes or crash their cars and end up in my trauma unit with blunt thoracic aortic injury. And as we know, the pathophysiology of this is in significant deceleration injury. The aortic arch is relatively fixed with the great vessels, but the descending thoracic aorta is quite mobile, and on serious deceleration, the descending thoracic aorta keeps moving to an extent, and we get a dissection avulsion process just at the very distal arch. And this is historically classified in grades 1 to 4. Grade 1 intimal tear, grade 2 intramural hematoma, grade 3 false aneurysm, and grade 4 rupture. And famously, the grade 4 rupture is what Princess Diana died of one night in Paris some years ago. So grade 4s almost never make it to hospital. But we're very much interested in the treatment of grades 1 to 3. Now, the problem with descending thoracic blunt injury is it is a high energy process and is associated with other injuries. So the placement of the stent graft itself is not a big undertaking. Now that we're all used to putting in stent grafts, they work very well and they're very well tolerated. Again, this is the Gore device that we use. They go in very rapidly and we can really rely on them. But the intricacy and the complexity and the case planning problems come when there are significant other injuries, which often happen in high-speed motor vehicle trauma. As you know, grade 1 injuries we often observe with observation and serial CT scans. Number 2, we might watch and wait or possibly fix them the next morning. But grade 3 with a false aneurysm needs treatment as soon as possible. And this is pretty straightforward, but complexity arises when other major injuries coexist. And I will talk you through a couple of cases that we've had that made the treatment of the thoracic injury more complicated than you would like. Here is Aberdeen University in the top left, pretty old building, and in the bottom right is our medical school where we run a lot of cadaveric simulated trauma courses, which is extremely helpful for when we're training the trauma team. So here's a typical trauma case. So this man, I'll not show you his CT of his chest but it shows a grade 3 aortic injury with a false aneurysm. But he's also got this very significant open book pelvic fracture, and you can see the complete disruption of the sacroiliac joint and complete disruption of the pubis. And of course, as we know, these are associated with significant pelvic bleeding problems, usually from torn venous plexuses in the pelvis. And so these patients come in. There's usually a long bone fracture. There's usually concern about the cervical spine and possibly the head as well. And we need to get these patients sorted from a multi-trauma point of view. And a blunt thoracic aortic injury with a shattered pelvis needs rapid liaison with the trauma team, and we need to get some priorities for these patients. And of course, we try and fix the worst bleeding first. And I'd say in a pelvis like this, we would say that the bleeding in the pelvis is imminently life-threatening, but then we need to get to the thoracic aorta as well as soon as we can. And so these patients almost always end up with a pelvic binder, and this is standard practice in shattered pelvis trauma, and these are supposed to go on centered over the greater trochanters. Now, as you can see with this mannequin, getting to this patient's femoral artery might be quite a challenge, and in fact it becomes really hard work when you need to get a thoracic stent graft into them. And what we do with these patients is, if we can get a stent graft in up the superficial femoral, then fine. Sometimes the superficial femoral is not big enough. Obviously, we prefer to go for the common femoral wherever possible. Occasionally, we need to take the binder off very carefully and very gingerly to get the thoracic stent in. And occasionally, we need to get the orthopedics to put an external fixator onto these patients. But I think until there's a definitive bleeding control in the pelvis, these patients are very, very unstable. The other option is that you gingerly take off the pelvic binder and get an assistant to manually compress the pelvis while you get your access in for the thoracic stent, and then reapply the pelvic binder and proceed with the rest of the case. But these pelvic injuries are challenging just from an accessing the femoral artery point of view. I'm sure the audience will have other ideas about how to get access in these patients. The next set of patients that give trouble with thoracic endografting are the patients with neurosurgical injuries. So with high velocity deceleration trauma, there's a couple of intracerebral problems we can get. First is diffuse axonal injury from deceleration, and that leads to diffuse swelling in the brain. Or they can have a neurosurgical bleed in the brain, both of which can increase the volume of brain tissue. And as we all remember from medical school, the Monroe-Kelly doctrine determines intracranial pressure. So these patients do often have increased intracranial pressure. And the problem with this is the intensivists or your neurosurgeons might want these patients run at least normal blood pressure and possibly higher blood pressure or supranormal blood pressure to maintain cerebral perfusion. In these kind of cases, when they want a blood pressure of 140 systolic and so on, you would be very reticent to treat a grade 1 or grade 2 conservatively because of the risks of thoracic decompensation because of hypertension. So if a patient's got a significant brain injury, we might be pushed into doing a thoracic stent earlier than we might want to, or in a lower grade because of the physiological demands of the head injury. So that's another thing to consider. It's difficult to justify hypotension if there's a significant brain or neurological injury. Of course, as from the aortic point of view, we would prefer a little bit of hypotension because it stops dissection flaps propagating. So in the neurosurgical situation, we might need to recalibrate our requirement for a thoracic stent. The other thing is it's standard practice when deploying a thoracic stent to make the patient hypotensive or even pace the patient to achieve greater stability of the stent graft immediately prior to deployment. This might not be possible in certain head injury states because of the previously described Monroe-Kelly doctrine. Those of you that put in a lot of thoracic stent grafts, we know the forces in the thoracic, in the arch of the aorta are tremendous, and without significant hypotension, you do see the stent kicking quite a bit. Mitigating factors against this is to put the wire aggressively up against the aortic valve and really squash it into the superior aspect of the arch to sandwich your stent and make it as stable as possible. But the hypotension that you'd normally ask for from your anesthetic team might not be possible in this head injury state. And then the final type of case we get is significant abdominal injuries. So as we know, serious decelerative trauma is associated with abdominal injuries, especially to the liver and spleen. But more and more, we're recognizing significant mesenteric tears. So this is a patient with a mesenteric transection avulsion injury and a significant intra-abdominal bleeding from the mesentery. We have had one case where the superior mesenteric artery was avulsed, although I don't have his pictures here today, but we've seen some horrible mesenteric injuries. In this kind of situation, these patients are horribly shocked and need a trauma laparotomy. And in this kind of situation, when you've got this volume of abdominal blood loss on an unstable patient, I would normally, with the general surgeons, do a trauma laparotomy and pack all this. Even if you don't achieve definitive control, that will give you some stability. And then at that point, once everything's packed, then you could proceed with a TEVAR if you had a grade 3 aortic injury. Of course, if you've got this much bleeding and it's only a grade 1 aortic injury, you might be very, very tempted to try and watch and wait for the thoracic problem. But this is a significant bleeding problem that we have had to deal with in conjunction with a thoracic aortic tear. So in these abdominal deceleration injuries, a TEVAR might need to follow on shortly from a damage control laparotomy. And of course, if you've got the benefit of a hybrid theatre, that's a much nicer place to treat these patients. Of course, open repair is always an option for thoracic deceleration injuries, but I think it's becoming less and less common with the advent of very reliable aortic stents. Not every trauma unit in Scotland has got a cardiothoracic unit on site, and of course in these trauma patients, open surgery to the descending thoracic aorta would require further opening of another major body cavity. And if that's required in trauma, then fine, but it's always nicer to leave a cavity closed if you can. So in summary, blunt thoracic aortic injury must be suspected in high energy or complex trauma. The TEVAR part of the treatment is relatively technically straightforward and well tolerated, but the timing of the TEVAR needs considered. We need to consider the requirements of other surgical specialties, other injuries, and what the ICU team need to manage this patient. And I think the takeaway message is that complex trauma care is best delivered by multi-specialty teams in trauma centres. Thank you so much for your time and attention.
I think we have to move on with you. A third one? Okay, so is it the... Thank you, Bryce, for coming in.
You're very welcome, and thank you for your attention.